Namaste, dear friends. Very glad to have this opportunity to talk to you. I have some very important matter to discuss with you. But before I do that, I want to ask you a question. Some of you may find that a bit of a difficult question. The question is, are you able to think about your own death, your own mortality? I do not even really now have the luxury of getting your answer, but fairly recently, when I asked this question to an audience, about 1/3 of the audience raise their hands. They are able to think about it. They have no problem. When I asked who finds it difficult to think about it, again 1/3 of hands went up. The other 1/3, that's roughly 1/3 was undecided. They were not sure. I addressed only the people who said they are able to think about it. People whose hands went up straight, no reluctance. I asked them, when your time comes, everybody will have that time coming up. Human mortality continues to be 100%. When your time comes, where would you like it to be? Would you like it in the best of intensive care units with all modern technology and facilities, where your slightest alteration, the heartbeat will be immediately picked up and a nurse will rush to your side and a doctor will do the needful? Or do you want it to be in a hospital room? Or do you want it to be at home? Among the people who had raised their hands, almost all of them said, I want it to be at home. A few said, I don't mind being in a hospital, but I want my family with me. Not even one of the doctors chose the intensive care unit. Is that what we do for our patients? These are some things that we need to think about. When eventually my time comes someday, I know what I would want. All the technology will be useless at some point of time. Some of may actually be a big nuisance. That tube inside my throat is going to feel like a red hot iron, and the suction catheter going in and being twisted as it is withdrawn will be total agony. In my pain and frustration, I may try to pull the tubes out, and then my hands and feet are likely to be tied. This is horrendous. Dying like that is the one thing that I do not want. I am an anesthetist, I am an intensivist. At least I was an intensivist. I know that intensive care can be precious. By picking up minute-to-minute alterations in non-vital functions, it can warn us enough to act immediately so that the other organs do not go into dysfunction. It can be life-saving in the appropriate context, but when return to a reasonably normal life is not possible, this is infliction of torture of no purpose, no useful purpose except stretching out the dying process to a few days or weeks, or worse still to months. Ladies and gentlemen, unfortunately, this is what's happening around us. I want to talk to you about this issue and how we need to protect ourselves, our loved ones, and the community around us from this kind of misadventure. Please permit me to share my screen. I wanted to show you by showing this link to the recent Lancet Commission report, which was published on 31st of January this year. This is called the value of death. The Lancet, the famous journal Lancet, periodically appoints commissions to look into public health problems and to suggest solutions. I have given the link there. I hope you will take a look at it. It's a long document, but maybe you can read the executive summary, the key messages, and the recommendations at the end. And maybe you would also like to see the few pages that are written there about how the community gets involved with end-of-life care in Kerala. I said I am going to talk in that context. I'm not going to talk only about the report. I want to talk first about how people live and die with incurable illness in our country, how it should be. And then I'll go on to the relevance of the Lancet Commission report. A British oncologist who now lives in Australia, a Bengali, Dr. Sankhamitra, an oncologist who cares deeply for the suffering in our country, who spends all his earnings. He lives on his wife's salary and spends all his earnings for the people in our country. And he wrote, in India, the poor die in misery of neglect, like this woman in a destitute home. The middle class die in misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. Maybe a slight exaggeration. Well, maybe 2% of people may get a dignified death, but it's as bad as all that. The woman is lucky. Those who have money on the pocket are destined to suffer like this. Death being stretched out to weeks and months with arms and feet tied, a fate that is not even meted out to people sentenced to capital punishment. This is much worse. What is the objective of end-of-life care? First and foremost, when my time comes, please make me as comfortable as possible physically. Treat my pain, treat my other symptoms, and help me emotionally by giving me honest information with compassion, and by allowing me to be surrounded by people who love me. Being able to give love, being able to receive love. And spiritually, the time that remains for me will be very limited. I want to feel connected to wherever I feel connected. For many people, it's to God and religion. They would want the holy book read, or they would want prayers all around them. For many, it may be just familiar environment, the tree outside the window. It may be the presence of loved ones. It may be the feeling that my life has not been in vain. These are the most important. The person, me, being made as comfortable as possible, first and foremost. Secondarily, also my family. Remember, they are also going to suffer enormously. Now they are made to wait endlessly in the waiting room outside the ICU, just looking at the door, waiting for some news, waiting for those 5 minutes of visit that are allowed. They need to be holding my hands when I am scared. And I need to be able to convey one last message to them. At that point of time, friends, please stop worrying about the vital parameters. The oxygen saturation is no longer relevant. If my condition is not curable and I am terminally ill, the serum sodium is of no relevance. 90% of us will go through a prolonged illness before we die. Only 10% of us will have a sudden death. And for all of us in that 90%, We cannot die with a normal serum sodium. As our general condition deteriorates, our sodium potassium pump will fail. Sodium will become more and more intracellular. There is no ATP available to push it out. The serum sodium falling is not signifying loss of sodium, it's signifying in that context. Not talking about reversible conditions causing hyponatremia. In this context, that serum sodium means intracellular accumulation of sodium. And if at that time you continue to give me hypertonic saline, it's going to be all get into the cells, drawing more water in, causing more cellular edema, causing interstitial edema. Stop asking what's the BP. Ask people, how am I? You may, till then, you may be changing my position every 2 hours to protect my skin. I consider it's ultimate failure if an intensive care unit allows a patient to go out with their pressure zone. It shouldn't happen, ever. But in the last day or last days, maybe you will balance that with a little bit of comfort. If at the end of 2 hours you find that I'm finally sleeping after 16 hours, maybe you can postpone that change of position by a few hours. What am I saying? Concentrate on comfort. This poor woman in a destitute home had nothing of earthly possessions, but she could have a few drops of water down the throat. Luxury compared to that man who is tied up. And communication. From 2019, medical students will learn communication. We did not till then, but we need to. I may be apparently unconscious, but maybe I'm able to hear what's the harm in communicating with me. Tell me what's happening to me. Allow me to get news of your son has come. He is here. He is holding your hand. Why not? You don't lose anything. Very often, people can hear. One of my friends said he had a stroke, was aphasic for 3 months, and he could not write. And when he eventually started communicating, he said the worst thing was during those 3 months, nobody ever told him what had happened to him. He had no idea. That the anxiety of not knowing is worse than getting the truth, however painful. And remember, the family's needs. I'll repeat this. The family's needs need attention. This woman died with one of the worst pains that I had seen. And there she was, sitting there on the floor and trying to do homework and looking at the mother with those painful eyes. What kind of scars will she be growing up? Nobody explains anything to the children. They grow up wondering within herself, is mom going to die? Is my dad going to die too? Will my grandparents also die? Who will feed me? What will happen to me? They have horrendous fears. The people need explanations. However fantastic your technology in the intensive care unit is, if we fail to communicate with the family, we are not doing our duty. And when necessary, religious rites must be facilitated when the person wants it. There can be two sides to it. I have actually facilitated against facing the wrath of somebody who was in charge of an intensive care unit by practically pushing a priest in because a patient had requested last communion. Nevertheless, to somebody who does not know he or she is dying, inflicting that last communion without introducing the matter can be a terrible mistake. A young woman, Sindhu, wrote an article in the Hindu. I have given the link in the bottom. I hope you will read this. This article says When Pain is Medicine, and that's in the Hindu, on 9 August 2016. Sindhu said, my 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized. She, in the article, she goes and requests, why do this? Why not treat his pain? They said it's dangerous. Pain relief will be dangerous. They were pointing out the kidney, something else. Maybe that kind of medical practice has lost its focus, its purpose. I'm not talking through my hat. The National Cancer Grid is a conglomeration of about somewhere near 300 cancer organizations in the country, cancer institutions in the country, led by Dr. C.S. Pramesh, director at Tata Memorial Hospital in Mumbai, oncologist himself. And they have published these guidelines. It's called Choosing Wisely India. They have several guidelines, and one of them is 10 low-value or harmful practices that should be avoided in cancer care. And it clearly says, do not treat patients with advanced metastatic cancer in ICU unless there is an acutely reversible event. Is that what's happening? For the majority of us, we'll find that this is seldom talked about. They know this, they have attended the meetings, but the hospital protocol is, if serum sodium drops below so much, move to ICU. If oxygen saturation drops, move to ICU. That, I believe, is unethical and a horrendous infliction on people, offending their dignity, offending their right to live with dignity. And remember, this is a particularly Indian disease, intensive care affliction, inappropriate use of intensive care. In Europe, this is not too old. The 2019 publication in European intensive care units, Sprung et al. Say, in 90% of cases, when treatment is considered futile, these people have artificial life support withdrawn and instead given palliative care for comfort and allowed to go. This has nothing to do with euthanasia. This is only about withdrawal of artificial life support, which is allowing natural death. Whereas this is even more recent. Last year, 2021, Dr. Raj K Man and colleagues in the so-called INDICAP study, they find that in only 70% of cases, as against this 90%, only in 30% of cases, artificial life support is withdrawn. 70%, they go through this. They go through continued life support till eventually the patient dies on a ventilator. This cannot be justified. What can we do about it? We need to prepare advanced directives today. A Supreme Court judge, India does not have a law covering this, by the way. We'll talk about it. But still we have a law, till the Indian Parliament creates a law covering end-of-life care. A Supreme Court judgment of March 2018, exactly 4 years old, holds valid. And ladies and gentlemen, according to the Supreme Court judgment, I sign a doc. I have actually done that, express my wishes and name a trusted person to take surrogate decisions. Maybe my wife, maybe my son, maybe somebody else. Of course, it has to be with the family's consent. Then the doctors have the ethical and legal duty to respect my wishes. I have written that. Doctors, you have the ethical and legal duty. Till a law comes up, you have the duty to respect my wishes. Unfortunately, the Supreme Court judgment brought in a few impractical procedures that I have to get it countersigned by the judicial first-class magistrate. I'm not going to do that. I'm depending on your goodwill, depending on my family standing behind me, supporting me in my decision, and your goodwill to operationalize my advance directive. But I have a question. Why should I write such a document to protect myself from a treatment which has no value, from a treatment that will only cause suffering for me? That's unethical. Why should I have to? People who feel that this is horrible feel helpless. Sindhu continues to write that I did not want to infuriate the doctors in whose hands we had surrendered his body and who had broken down his body into isolated segments only they could put back together again, if at all. Sindhu means by the isolated segments. Okay, let me get another opinion from the nephrologist. Oh, the cardiologist will see him tomorrow. We'll think about pain relief after that. Our system is operating within silos and not connected together. And therefore, the family is helpless. The issue is we need to be clear what our duty of care is. I find when I talk to young doctors that many young doctors believe that they have a responsibility to prolong life at all costs. Stretching out the dying process and keeping the heart beating for 4 more days, they see as their duty. They see it as their duty to check the chemistry by poking more needles in, even in those days. Whereas, though India has not defined the duty of care of the doctor by law, a statutory body of the government of India, the Indian Council of Medical Research, has had it defined by its bioethics unit. I have given the link there. Any of you can have this document. It is available for free download. If you Google for ICMR India, definition of terms in limitation of treatment or something like that, it will spring into view. So, bioethics unit of ICMR defines the duty of care as this. The duty of care of the healthcare provider is to mitigate suffering. It is to cure sometimes, only sometimes, relieve often, and to comfort always. This you have heard from our medical student days. And they add, there exists no exception to this rule. End of life is not an exception. If anything, it's an additional reason why this should be the focus. If people are dying, and if we are unable to bring them back to reasonable quality of life, we should mitigate their suffering, relieve their symptoms, give them comfort care. There is no exception to this rule. And in 2014, the World Health Assembly, that's the decision-making body of World Health Organization, asked all member countries to integrate palliative care into healthcare, into all of healthcare, including end of life, including critical care, all healthcare at all levels, primary, secondary, and tertiary, hospitals also, across the continuum of care from the time of diagnosis to the end. You have to treat symptoms. You have to give psychosocial support. These are mandatory. India is a signatory to this convention. This is the background in which I bring up the Lancet Commission report. There are many recommendations. I'm not bringing up all of them, but I'll bring up some of them. One, all of us who belong to the health system should remember the management of suffering should sit alongside extension of life. as a goal of healthcare. Dear doctors, you and I have to accept the responsibility not only to keep the people treated for their diseases, but also treat the suffering. And education on death, dying, and end-of-life care should be in the curriculum of every health student, medical student, nursing students, and social care student, and in continuing care of education of practicing professionals. As I said, from 2019, students, medical students have it in their curriculum. From 2021, nursing students have it in their curriculum. Many of us are here without that education, and somehow we need schooling in this. We still just have not been taught how to do it. We need to learn how to give them comfort care, and every hospital should be able to access palliative care professionals who can assist when we ourselves are unable to do this. Patients and families should be provided with clear information about the uncertainties as well as the potential benefits, risks, and harms of interventions. Not a head coming out of the intensive care door and saying, his BP is dropping, we need to put him on a ventilator. He's not breathing adequately, we need to put him on a ventilator, if not, he will die. Then the family is emotionally blackmailed into saying, yes, please go ahead, money doesn't matter. Instead of that, all the risks, benefits, and harms of interventions need to be explained to the patient. Now, these are just some of the recommendations. Remember, they are not talking only about health systems. I've created this image to show what are the barriers. I said doctors need to be aware of this. We can't do it alone. If I gave you enough time, you would come out and say, families demand it. Of course they do. If my loved one is dying, I would be with you saying, please help him, do anything, please save him. That's what I want. But if you explain to me, if you are compassionate, and somebody in the team, I know you are a busy doctor, why don't we have more social workers doing this kind of thing in ICUs? If somebody sits down with me, allows me to vent my, I may take some time, but after 6 hours, I'll come and say, doctor, or 2 days. In the meantime, you shouldn't escalate any life support measures. I would say, doctor, please keep him comfortable. That's all I ask. There will be many societal factors, including religious beliefs. Societal factors worst is now, just in 25 years. Till the 1990s, this didn't happen. But now, the man on the street or the woman on the street sees dying as normal if it happens in the ICU. So even if my children decide, okay, we'll keep him at home as he wanted to, or we'll keep him in the hospital room so that the doctors can give him pain relief, but we'll stay with him. Then the uncle, the distant cousin, and the friend from Dubai will come. Hey, you're keeping him here? He's your own dad, right? You don't want to spend money on him? He should be in a good ICU with excellent facilities. This is happening. Who will educate them, ladies and gentlemen? They did not know this 25 years back. We, medical system, initiated the practice of end-of-life care, intensive care, end-of-life intensive care. Now they have come to believe this. This unlearning also will have to start from us. We will have to, as the Lancet Commission report says, we will have to be the agents of change, promote death literacy. In my childhood, death was not a stranger to us children. We were familiar with this. But today, Death is a stranger to children. They have not seen death. They live in nuclear families. There is no sense in romanticizing the past. There were plenty of problems in the past also. But we have to recognize that today, death is a stranger and it has become the enemy to be feared at all costs and to be fought at all costs. We no longer accept death when inevitable. This means what I am doing now with you, ladies and gentlemen, we will have to go out and talk to the public. Many of you must have read Atul Gawande's Being Mortal. He talks about the citizen doctor. I'm not only a medical scientist, I'm also a human being with a responsibility to fellow human beings. I think we need to be advocates for the dying. There is a bit of a legal hassle because it is not defined by law. Unless there is death literacy, a law is unlikely to happen. In fact, in 2016, end-of-life care law was proposed. It was published on Government of India's website. They asked for public comments. More than 1,300 opinions went in, including our submission on behalf of a palliative care organization, but it was not pursued. In our system, if a law is proposed and is not tabled in the parliament in the duration of that government, it is null and void. If it is to happen, it has to start again. Till then, the Supreme Court of India's decision is valid. On the positive side, it validates advance directives. It permits and recommends withholding and withdrawing of life support when futile. Unfortunately, it has put in an impractical and complicated process. And also, it calls withdrawal of life support passive euthanasia. That is not correct. It's technically incorrect. Okay, you go to Wikipedia and frame laws around it, you will find that. But all scientific literatures agreed that withdrawal of life support in the context of incurable illness is not euthanasia. Euthanasia is an intentional act of killing someone. Passive euthanasia is also facilitating somebody killing himself or herself. We are not doing that. There is a great difference between that and allowing natural death. We are only removing artificial systems which are sustaining life, allowing a natural death to continue. It's not my personal opinion. That Indian Council of Medical Research document puts it out very clearly. International bodies, like many international bodies, have said the same thing. Many international guidelines, like the guidelines for dementia care, actively talk about preventing such artificial life support from happening. But it is continuing. And that is unethical. And I am worried about myself and about all of you and your loved ones. We are not talking about somebody else, mind you. We are talking about our loved ones, our parents, our uncles and aunts, and ourselves. We need a reasonable quality of life. Till we are actually dead, we are alive. This is about life more than death. We are not only asking for quality of death, we are asking for quality in living to the last moment. Despite the uncertainty of law, it is quite possible to overcome this with the family's consent. I know there will be some situations where there will be lack of clarity, where half the family will pull you one way and half the family will pull you the other way. At the moment, I am not suggesting a solution for all situations, but I am certainly suggesting a situation where we work in partnership with the family, educate them, and where they and we are in agreement, the legal objections are not there. We can take a decision based on our duty of care. But we cannot do it alone. We have to engage the media. Doctors, I hope you will write articles, talk to the media, talk to members of parliament, because this is absolutely essential for you and I. Please think about it, and I hope our organization will take it as our mission and do something about this in course of time. Thank you very much.
Hello. Hello. Hello, everybody. Could I be heard, Deborah?
Yes, sir. You are audible, sir.
Yeah, thank you. Thank you, Dr. Rajagopal, for presenting your views on death, the dignity of death, and dignity of life. And you are presenting, there is no reason to have over-treatment during terminal illness, or say when you are in irrecoverable illness, as well as there is no reason to find out the chemistry of body parameters every day in an intensive care unit. But the trend has come that way, and we are to be educated what to do good in terminal illness. Thank you for narrating about the advanced directive. Now I request Dr. Raj Mani to give a sum total on the Lancet Commission and on this present malady, how it is directly affecting us. Raj Mani has something like 3 decades of exposure in the intensive care, and he is one of the leading intensivists of New Delhi, and he is connected this moment. I request Dr. Rajmani to come forward and give your views.
Thank you very much, ICA and Dr. Radhakrishnan and my colleagues for this opportunity to listen to Dr. M R Rajagopal and to share my views on the subject of end-of-life care. Now, to summarize what Dr. Rajagopal has said, he began by talking about mortality. You know, it's so difficult for us as caregivers to think about our own mortality, which is so important. So he said that when he put this question to caregivers, then only 1/3 were clear as to what they wanted. They did not want death in the ICU. On the contrary, they wanted a peaceful and dignified death at home. Now, when clear-thinking individuals in our profession think so, why don't we give the same attitude when we treat our patients? Why don't we want the same thing for our patients? That is the question he started with. Went on to the question of futility of treatment at some point in intensive care, which we seem to ignore and keep going, stretching out the dying. And this has been a major public health problem, major existential problem in our profession, particularly in intensive care, where we see at least 1/3 of the patients terminally ill. More and more terminally ill, infirm people are coming to the ICU to die. So this has been the trend. The Lancet Commission was in place only for this reason, or there appears to be a strange paradox in medicine. While many people, most people in the world are deprived of life-saving treatment, most people who are dying in the ICU seem to receive disproportionate care. This is the paradox. We seem to have lost touch with reality when it comes to mortality. Before the 1950s, before the advent of intensive care, before the advent of an intensive care unit and resuscitation, it was quite natural to die at home amidst the family. So the children and subsequent generations were familiar with death as a part of life. Now, what has happened, the Commission says, is death has become artificial. We are not familiar with death. We seem to regard it as something we have to defy or deny. And in so doing, we torture it and we deny death its meaning. So they go on to explore the intersections of death and dying with culture, with the nation's welfare schemes and governance, with the ethics, with the religion and religious practices, with connection with our past, that is history, and so on and so forth, with the socio-economic, particularly healthcare economic regions, and also with aging, also with inequities. So there are at least a dozen or so conditions that they explore the intersections. So it runs into 120 pages. It also forays into humanities and philosophy. So what is the sum and substance? Sum and substance is that we seem to have lost our grip with how to deal with mortality. And we seem to have used science, in fact, to create more problems. In fact, to complicate death. As Dr. Rajagopal quoted Dr. Sankha statement that no one gets a pain-free and dignified death. So that is what has happened. Neither the high-income countries nor the low-income countries seem to have got the right approach to death. So, however, what has happened is, in the West, particularly in the US, and the Society of Critical Care Medicine was set up in 1971 in the US. And into the late 70s, the critical care community started to realize that there are limits to what the intensive care can do, limits to our capacity, our expectations, and therefore treatment limitation approaches had also started simultaneously. I must say, we just got our DNAR guidelines from the ICMR in 2020. There was the first DNAR decision was taken formally in the US in 1974. And the codified law came in existence in 1988. It is not that the intensive care community was unaware of the harms and the ethical limits we were crossing in our overzealous application of intensive care. So since the late 1980s and 1990s, more and more surveys, observational studies, research in terms of intervention started to occur in the field of intensive care, and there was a huge profusion of mainstream research publications on end-of-life care in these decades of 90s and 2000s. My own publication on ethics of intensive care in India was published in 2003 in the Indian Journal of Critical Care Medicine. One of my observations, and which was very painful and in anguish, I wrote that there was no treatment limitation formally carried out in our ICUs. And very importantly, what we were doing was Lama, a very appalling practice called left against medical advice. Wherever we are placed with a moral dilemma of when to transition from curative intent and curative treatment to a palliative care approach, we never faced those questions. Instead, when we could not have a reasonable decision making, we sent the patient Lama, or allowed the patient to take the family to take the patient away in a critically ill state without any benefit of palliative attention. And this we did because we were totally unaware of the complexities of dying in the ICU, the need for a dignified death, need to confer with the family as to how to provide a care which was in line, in concordance with the values of the patient. None of this was there. Actually, I went to a Supreme Court lawyer at that time and actually found that there was no law at all touching upon end-of-life treatment limitation. There were only two case laws, which were Gyan Kaur versus the state of Punjab and P Rathinam versus the Union of India. Now, these were about, one was about abetting suicide, and another one was wanting to commit suicide facing a terminal illness. But none of them really explored the whole of EOLC. With this in view, in 2005, the ISCCM, Indian Society of Critical Care Medicine, set up an ethical task force, of which I was the chairman, and we published our first paper, the End-of-Life Care Guidelines, in 2005 in the IGCCM. You will find it for a free download on the net. So we went on to approach the Indian Law Commission, Justice Jagannatha Rao, and the first draft paper was published by the Indian Law Commission in 2006. It is 196th draft. Unfortunately, it was never tabled in Parliament and it didn't come for discussion because in our country, these issues are not properly prioritized. Be that as it may, they had clearly indicated that none of the withdrawal withholding decisions are in any way euthanasia, that is active euthanasia. As Dr. Rajagopal had said, they are not at all euthanasia or suicide or abetting to suicide. That portion was clarified, but the 196 report did not endorse advance will at that time. The guidelines were revised in 2012 by the ISCCM, and in 2014 we further revised it in combination with the Indian Association of Palliative Care, IAPC. It is called Coming Together for the Care of the Dying. Okay, improving the care of the dying. So we also included all palliative care principles. The guidelines had a 12-step process for end-of-life decision-making. The principles are that we have to identify exactly where, to the extent possible, the patient entered terminal illness, a point of no return, and then it is more beneficial to have a palliative care rather than curative care. That is, curative care gave way to palliative care. So we discussed how to identify or which are the scenarios we identify to start thinking in these lines, first conferring within the treating team and then presenting that to the family. So for the first time, the ISCCM talked about the intervention of communication and conversations. It's called family conferencing. So these are the communication is the main intervention in order to provide proper care to both to the family and the patient so that it doesn't become excessive, so that we can achieve what Dr. Rajagopal has said, treating wisely. So treating wisely is an international movement started in the United States. So they formed guidelines in each specialty. I'm extremely glad that Dr. Parmesh from the Tata Memorial and his colleagues have formed treating wisely principles for oncology. This should spill over to intensive care and other areas. So I want to say a few words about the law. Now, we have from the professional societies, not only of India, of the world, we have an end-of-life care decision-making process. That's all very clear, right? There's a 12-step process which has its own checks and balances so that we minimize mistakes to a minimum and minimize and maximize transparency in this process and documentation. These are extremely valuable and important. Whereas when it comes to the law, most of us seem to be still unaware that we have the constitutional validity, constitutional sanction for withdrawal withholding decisions. We all seem to think that there is no law and therefore we cannot do end-of-life decisions or treatment limitations. That is not true at all. In 2012, in the Aruna Schonbock case, the courts clearly declared that the so-called passive euthanasia, you see, what they mean by passive euthanasia is withdrawal withholding, are allowed by the court under certain conditions. So in principle, they agree to what we say, but in action, they put so many barriers that it becomes non-actionable. Okay, this is what exactly happened. But we started a campaign called, the Common Cause versus the Union of India is a campaign started by the Common Cause NGO for having advance will or advance medical directive, a valid legal document in India. Initially, 196 report had disallowed it. So that is why this court case came about. I, on behalf of the Indian Society of Critical Care Medicine, pleaded in this case in support of this argument, and also included the question of withdrawal and withholding, that these are respectful of patients' autonomy and therefore should be valid by the Constitution. In the year 2018, in a 11-judge bench, constitutional bench, they validated, they allowed advance will as being respectful of citizens' autonomy. Now, autonomy is guaranteed as a fundamental right in the Article 21. So it's specified further that autonomy is valid. We have always recognized through common law that autonomy is valid. That's why we take consent. No treatment, whether to the benefit of the patient or not, can be applied without consent. So that's based on the autonomy, that is the right of self-determination over one's own body. So that cannot be violated under any pretext. So that was further validated by the Constitution, and also withdrawal and withholding, they are on the same level. There is no difference between withdrawal and withholding. It is not that withdrawal means that it is a euthanasia and withholding is okay. No, both are the same. If taken in the context of futility of treatment, both are ethically the same, and this is what is held throughout the world and also in modern bioethical principles. Where we have lost out was that they prescribed a 3-tier process, and that is not feasible or it is unworkable in the intensive care setting. That's only possible when we have several months on our hand to go to courts and all that. So we have submitted. Now, I want to tell you, there is another advocacy group which was formed, which is called ELICIT, End of Life Care in India Task Force, with 3 professional societies: Indian Society of Critical Care Medicine, ICA, Indian Association of Palliative Care, IAPC, and Indian Academy of Neurology. So these 3 societies, of which I'm a chairman of this ELICIT, we worked with a legal think tank called Vidhi Center for Legal Policy, based out of Delhi. They also advise the government on many legal conundrums. So we created a model end-of-life care bill with several consultations, and this has been submitted to the government. So you will find this also, modern end-of-life care bill, on the net, you will find it by Vidhi Center for Legal Policy. And together with Vidhi Center for Legal Policy, the ISCCM has also submitted to the Supreme Court a clarification appeal for clarification and simplification of the process in law. So this is also yet to be heard and followed. In conclusion, I want to say that there is a lot of vigorous activity, advocacy by professional and lay public in this field of end-of-life care. It is everybody's problem because we are faced with great inequities, disparities, and resource crunch in our country, and also a lot of avoidable suffering by imposed treatment at the end of life. What we must do is, as Dr. Rajagopal summarized, we should set the goals of care very clearly, and we should include this end-of-life care and awareness in the curriculum, that we must satisfy the information needs of the families and the patients. We must address all the 4 barriers that he showed us, starting with the patients and with the physicians' attitudes and understanding, with the families' awareness and education, with the societal factors and the law. We must address all of them and also raise the awareness, raise the conversations around death, so that we normalize a conversation around death, so that we make it natural and we don't have this sort of artificial relationship with death and time. Thank you, Dr. Radhakrishnan. Thank you for your patient hearing, my colleagues.
Thank you, Dr. Mani, for making the concept more clear. It's becoming a fact that death in India is getting costlier. Whether you are down in south or in the north, death is somewhat miserable and costly, because we are all getting overtreated. And the only doubt what I have, is there any autonomy for the patient in an ICU? That matter has to be discussed in detail. Before that, I request Dr. Chakra Rao, who is an ex-director of Health Service of Andhra Pradesh, and is the chairman of research station, which is moved by the Indian Society of Anesthesiologists, and is chairman for that research. And he is a national president of.
Good evening, sir.
Yeah.
These circumstances I have faced running an ICU many times. Many times the patient relatives getting the treatment in some corporate hospital and bring it to us. You don't treat anything. She is already, we have already committed that the patient is going to die, and you admit. So can we admit the patient and keep her in a room without giving IV fluids or without testing electrolyte, or are we justified? Is it not a problem legally after 2 months or 15 days or 2 months or 3 months? They may go and so that even though we have taken her, they have not treated anything. It is a difficulty actually I have faced many times. But I used to maintain the case that I've been giving treatment and not charging them. And it is also think sometimes there may not be a protective airway, there may not be an IV line or something like that. And but they don't want that patient to die in their house. They don't like to take them. But how far we are justified in treating these patients without giving any treatment?
See, sir, treatment has a goal, has a purpose. We are not obliged to give any medical treatment in the absence of any benefit. You know, the first premise of medical treatment is it's the benefit outweighs harms. Okay, that is the basic justification for putting anybody on any treatment. And putting anybody on any treatment requires consent. These are two things. So if the family believes the treatment is going in nowhere and they're only being burdened, the patient is being burdened, and the physician agrees that putting this patient on a ventilator, for example, is not going to be of any use. It's only going to harm. It's going to impose a lot of burdens. It's going to produce a lot of physical and psychological harm, and a lot of economic burden and psychological harms to the family as well. So this decision is a collective decision between physicians and the family. And this is what the end-of-life care guidelines have delineated, how to arrive at this decision. And through conversations and how to document this. There are forms. You will also find the Manipal group of hospitals creating a document like this. That is called the Blue Maple. It's got all the forms, it's got all the SOP procedures, how to do it. This also you'll find on there. So if we follow this procedure and we document appropriately, then of course, see, a surgeon can take a decision not to operate because it's not in the interest of the patient. Even though patient is dying, he will feel, he or she may think this is not going to benefit at all. So a good surgeon also knows when not to operate. So similarly, a good physician knows when not to put a patient on a ventilator or when not to initiate resuscitation. For example, CPR is futile in a terminal illness, or somebody who is already in the last legs in the ICU, a CPR is of no use. It will only increase the expense of the family by 50,000 in just that 1 hour. So, and the second part of this argument is, if the family refuses the treatment, okay, they are at absolute right, because this is also a law, that you cannot override the refusal, treatment refusal, either by the patient directly, if he's conscious, or through an advance will, which is already documented. Valid advance will is there that I don't want to be on a ventilator. It would be a violation of the law to put that patient on. So in the absence of an advance will, the family is the surrogate, or if there is a surrogate, a proxy appointed, then that person can refuse in a documented manner any life support. So with these two provisions, these two conditions, you can very correctly, ethically and morally and professionally correctly, you can implement these. And I have done so for the last more than 15 years. I've also published my findings in the intensive care medicine in 2009, end-of-life care decision in an Indian intensive care unit. You can look it up. There are 88 deaths in the ICU for that duration of 1 year or so, and out of which 50 of them had an end-of-life care decision. A majority were of withholding, but there were a few of withdrawal, and there were also DNAR alone. So these have been done, and I've also, of course, and on a daily basis, I do practice withdrawal, withholding, and DNAR without any problem whatsoever. Only my rapport with families and my communication skills are improving.
So
Thank you, Dr. Mani.
how long you can keep the patient, unconscious patient, of course, not dependent on ventilation or anything, but even without even giving a simple Rengerlactate or saline, how long you can keep the patient and no medication, no testing, nothing, and are you justified in leaving that patient? It is all.
You see, you're justified if it's a terminal illness. See, for example, a metastatic cancer.
And your publications, but have you brought it to the a district hospital level? All your things which are in the courts and distributed and all those things, what are all you people are doing from 2005?
I think wherever
have you percolated your use to the people who are working down the line at a district level?
You see, I'm an active intensivist. I'm working on the ground, and all this has been done personally by my team. And at every fora, whether it is Indian Society of Critical Care Medicine or Indian Association of Palliative Care, or in neurological societies, or in any public fora, we have said this can be done. It is done. Now there is a procedure, like for anything. You are asking whether we can stop giving any fluid. You see, there is a procedure for stopping giving fluids. Firstly, you have to fulfill the fulfill the criteria. Is the patient really terminally ill? Is, okay, providing food and nutrition, all right, is providing a food and nutrition necessary by artificial means? Is the family agreeable? If the family wants this continued, you have to continue. If within the treating team, they want nutrition continued, it continues. It's extremely rare decision not to give nutrition, but it's a very common decision not to give meropenem. It's a common decision not to do a surgery on these patients. Very common decision not to do dialysis. So it depends upon the individual intervention. Now, it is not necessary for us to do biochemistry every day and X-ray every day in a terminally ill patient. You can do it selectively to begin with. And after some time, it's very clear that in a few hours' time, the patient is going to die. You're not going to subject that patient to all kinds of biochemistry or, tests or blood culture. These are all totally useless at that. So, of course, you have to individualize that. There's no doubt about it. You have to individualize, and we have to follow those ethical principles and the algorithm. Okay, firstly, the diagnostic algorithm, how to arrive at a diagnosis of terminal illness, and secondly, the decision-making algorithm. And then you have to be transparent. You can't do it fishily. You have to do it transparently, and that is what the court is asking you to do. See, these are the ethical basis of ethical decisions.
The question is slightly different, Dr. Mani. What I believe Dr. Chakra Rao was presenting is that somebody with an irrecoverable illness or say metastatic cancer who was there in a corporate hospital for some days together, and one day they are shutting doors, telling that, well, we don't be able to offer any further treatment to this particular patient. Patient is going to die slowly. You may take the patient out to a new hospital or a nearby hospital to your home. Okay, that patient lands in Dr. Chakra Rao's clinic. But how far Chakra Rao is justified in not providing any fluid? Because the family wants treatment. There is no advance directive.
If family wants treatment and
family don't know,
family and Dr. Chakra Rao,
family is illiterate. They don't
illiterate.
know.
Yeah. So if the family is illiterate and doesn't want treatment, Dr. Chakra Rao, of course, will engage with a conversation, okay, and put forward in a simple language, in a language they can understand, what is futile treatment. If he puts him patient on some sort of treatment, say antibiotics or some form of fluids, what is the benefit and what is the downside of it? Both have to be discussed. It is not that this patient, if he receives meropenem, he is going to come alive or is going to have any kind of benefit at all. But giving meropenem may cost 10,000 rupees per day. Is that justified? In fact, when we talk about ethics, we are asking ourselves a question. I am putting this patient on this treatment. Is it justified? Is it morally, ethically justified? This is the question we have to ask. Not the question that is it morally, ethically justified not to give meropenem. Of course, if it is not indicated medically, it is not necessary ethically. It is in fact unethical to start it when it is not indicated medically. So the first question is whether it's indicated medically or not. Second question is you put this to the family. And the family, in spite of persuasion, they are not able to understand this principle. Then we are obliged to, of course, continue with whatever treatment that is possible. That has even just a very marginal benefit. Even then, you're not obliged to give an expensive antibiotic. You can still give an inexpensive antibiotic for two reasons. One is you don't want to impose on the family just because they are ignorant to understand the implication. Number two, you don't want to spoil the microbial flora of your ICU or your hospital. That's also a responsibility we have. That's also an ethical question. For a terminally ill patient, you're using antibiotics and vitiating the atmosphere for those public who can be treated effectively with antibiotics, and they require that medically.
I agree most of your arguments and how you are arriving at. The question is that none of our doctors are not that much keen to explain the plus and minus of each particular treatment there. And our people, most of the people are illiterate, especially when coming out of the health matters. In such situation, patient is not able to take, patient is unconscious. patient is left to nobody. Family don't know what to do with him. How far we are justified in avoiding treatment? Will a law will come against us
Yes,
for
yes.
doing that?
How
No,
far,
sir, the law is asking us.
how far
No,
we
no.
can protect ourselves?
The law is asking us to inform the patient properly. Law is asking us to take informed consent, which doesn't mean getting a signature on a paper. It means we are supposed to discuss the pros and cons of whatever proposed treatment it is, whether it's surgery or medical treatment.
It is not
There
happening.
is no argument. There is no
nowhere it is
argument
not
that
happening.
before surgery, you are taking, for want of time, you're taking a hurried consent
Yes,
and not having explained anything, pros and cons, you're doing
if
surgery.
you discuss
So-
all the problems with the patient, nobody will come to the surgery. Do you think it is happening in any of your standard of hospitals that you are explaining all the complications of surgery?
You see, we are talking about what is ethical and what is not ethical, what is legal and what is not legal.
Not the
You see,
theory part.
on
What
the
is
on the
practically
ground,
happening,
we are
I
not
wanted to
on the
know.
ground, we are not practicing extremely well. Let us understand that. But we must have our standards very clear. The standard of treatment is to take an informed consent. Although we are compromising it on the ground, all of us are doing it. But if in the law court, that is not a justification or a protection for us. The law will ask you whether you took an informed consent or not. So what I'm saying is, for our own protection, if you are afraid of the law, then as far as possible, we should be on the side of the law. I do take care when I do a bronchoscopy to explain to the patient. We can't say you may die on the table. That's not the way we put it. We put it properly, but we have to explain the major complication that can take place. You can have a pneumothorax, you can have a bleeding, but by and large, it doesn't happen. By and large, we do well. We have to explain, but we can't keep the patient in the dark and take a signature. So that the law doesn't take kindly. So what I'm saying is,
Are you
majority
explaining
of the
all those
times
things
we are
to the-
afraid that if
when
I
you are
don't
doing a
do,
bronchoscopy?
see, the error of omission is what we are afraid of. But we are not afraid of the spirit of the law. Spirit of the law is we have to be reasonably open and we have to document.
The spirit of the law is excellent. You are justifiable in doing what? But most of our people, the treating physicians or surgeons or obstetricians, they are not bothered about explaining all ill effects on such sort of drastic treatment, especially in terminal illness or with a metastatic disease. Well, we are. That means we ourselves are hiding from the public what is absolutely necessary. That means we are not at all going into an ethical conversation.
As long as he is paying these daily bills, you will not do all those things. Otherwise, you will be knocked out by the administration for not.
Now we'll go into that chapter later.
That is usually happening. That is usually.
So this is the barrier, sir. These are the big barriers.
You are talking, it's all ethics. Okay, everybody knows ethics.
Ethics is good. In fact, advanced directly we have to educate the public as well as our own crowd. I request Dr. Ranganathan, if you are available anywhere here, to come with your views on the matter.
I think Ranganathan is not here.
Has he joined?
Ranganathan is not here, sir.
Okay.
Even
Then I request
about 2 hours back from.
I request
Changalpattu.
our Jayashree Sood, CEO of the ICA, to present her views on the matter. How far ethical we are today. And
good evening.
Yeah.
Good evening, everybody. Good evening, Dr. Chakra Rao. Of course, I've already wished Dr. Rajagopal and Dr. Mani. Well, it has been a very, very thought-provoking webinar. And as Dr. Radhakrishnan is asking my views on this, well, palliative care and palliative medicine is, I mean, we all know it, but I just wanted to reiterate, is a specialty. And as we all know again, that we have post-graduation in palliative medicine now. So really, when we go, people who are really interested in palliative medicine and how they go into that, I mean, it's a branch by itself, and it means takes a lot of dedication and time to really study the whole thing. So as we could hear Dr. Mani, we could appreciate how he has started practicing this. Of course, he's been doing it for so many years, and we were very sort of impressed by his lecture and all the things that he told about the legal and the ethical concepts as laws, and also how he is practicing this in his daily routine in the ICU. And especially, I think what was the take-home message and the point to remember is the communication part. I think the family has to be taken into confidence, not in one day, but in several days. And this time spending, like when we have, Dr. Radhakrishnan, you'll be happy to know that we have started DNB palliative medicine in our hospital. And the people, we have staff nurses, and they take hours and a lot of time in counseling the relatives. So that takes a lot of time and dedication. So I think, although the law, etc., we have to follow the law, but this communication and end of life care and all is definitely can be practiced. Of course, it's difficult, as Dr. Chakra Rao was asking this question to Dr. Mani, that what would it happen if the patient went into a periphery? I agree. And as far as the education for the peripheral and the small areas or the smaller towns, it's going to take several years. It's still in the tertiary hospitals and the tertiary cities that we are having this problem. So it's going to take a long time, but Dr. Rajagopal and Dr. Mani, of course, have been working for years together, but we people, or the youngsters, now that the curriculum hopefully should start in the undergraduate as suggested by the stalwarts, should make a difference. So definitely it's very, very tough, but it is being practiced.
Thank you, Dr. Jashi. Is Dr. Beljit available anywhere? Beljit, do you have any opinion on the matter? Dr. Beljit?
Sorry.
No, I believe Beljit also is busy. Anyway, Dr. Rajagopal, I believe you are hearing. Can you answer, or you like to make up any sort of a sum up comments on the discussion we had for the last 80 minutes or so?
Rajagopal is not there.
No, he's out of the country. Yeah.
Sanesh and Moderator Kanchi are there.
Yeah. Okay, good. So I may come back to Mani once again. Mani, what is in the future holding for us in this particular situation? Well, you had to make the crowd literate, and we had to make people understand death is a natural process. Death is there. Once you are born, you're going to die another day. And people has to understand and how death should be made more comfortable to the individual. How that is made possible, as well as we should move this need of an advice directive produced at least by the people who are literate in the matter. And again, to our own crowd, that means unethical treatment has to be avoided. That also has to go. What's your view of Mani on these matters? Dr. Mani?
That's a very interesting question, sir, Dr. Radhakrishnan. See, increasingly the attention is being paid to the quality of death. So far, the quality indices included mortality rate. Now they also include the quality of death, quality of dying index is being computed since the 2010. India was placed 40th out of, I think, 40th out of 50 countries or so. And then the quality of death index was published again in 2015. we were placed at 60th among 80 countries. And now recently, 2022, we improved a bit. We are 59th out of 81 countries. Be that as it may, we have only the African countries and the low-income countries below us. So the UK, Australia, the Netherlands, now these countries are at the top, among the first 4 or 5. We have a lot to learn in this area. We have learned a lot. We have bridged the gap in the advances of technology. We have bridged the gap perhaps in a lot of cutting edge healthcare practices. But we have got a lot of ground to cover in public health. We have a lot of ground to cover in this quality of death, which impinges on the ethics and the laws of the land. So this awareness has grown, and therefore the government itself has focused in the latest healthcare policy on palliative care. I've gone through the document. It emphasizes palliative care at all levels, primary, secondary, tertiary. However, it does not mention death and dying and the quality of dying. So this is missing. I think the palliative care specialists and others in the profession must point this out to the government and bridge this gap. When the public awareness and the healthcare implications, now we see the aging population is increasing tremendously in India. With it also comes the problems of the aging and problems of dying of the aged, and the extra burdens on the aged, and also the healthcare economics. Millions are being pushed below the poverty line because of even a single ICU admission. I think 40% of the families in one of the surveys, the National Sample Survey, says that they, in some way, they become economically less than what they were before. All right, they have either sold land, property, or they lost jobs, or they've decreased their income, or they've taken loans, they've gone in debt. So all these things put together has clearly shown us that the current practices, the current views that we are holding on to cannot last. That is why the public, rapport of the medical profession of the public is deteriorating very much. There is always an anger. We are not able to bridge this gap. So I feel that if we take this campaign forward of improving the end-of-life care practices, improving the quality of death, it has many ramifications. It will have many salutary ramifications. If there is a public awareness, which should start with the professional awareness, of caregivers, of what we need to do, we can go in a concerted manner to the law and legislation and have a model end-of-life care policy and legislation for India, and also have it percolated to every district. Now, I must tell you, All India Institute of Medical Sciences, Delhi, has come out with an end-of-life care policy, which includes withdrawal and withholding, okay, and DNAR. So this was published in as an institutional policy in the year 2021. I think it will come as a publication in a journal very soon this year. I must also mention one
policy. You said All India Institute started a policy. Can this All India Institute policy could be extrapolated to everywhere? Well, the apex institution of the government of India is making a policy directive. Why can't that policy directive made universal, at least?
Of course, it has got the potential. What I mean to say is, you see, I think unless it comes as a government notification, or it comes as a movement within the profession, all right, we have got these policies. Please, let's implement them. Let's do our best. Of course, there are barriers. Of course, there are problems. Of course, the legal issues are still ambiguous. But if we have a movement, then there will be a way forward. This is what I'm trying to say.
Is that directive in force? Are they practicing that directive? The All India Institute directive?
They are, sir. I think Dr. Sushma Bhatnagar, the professor of palliative care in All India Institute, has already put in place a training program. I think it's been going on for a year and a half. And many of these things they've started to follow on the ground. Okay, conversations, getting getting a documented decision on withholding, getting a documented decision on moving patients back home and providing palliative care at home. These things are actually being practiced. So
Thank
this
you.
is possible. This
Thank
is
you,
actually
Dr. Yeah. Thank you, Dr. Mani, Dr. Chakra, Dr.
Thank you, sir. Thank you, sir.
Yeah, Jashi. Is there any question, Dabalina, from the audience?
So we
Is there
cannot
any
see any question till now from the doctor's side, sir.
Yeah, okay, that's also good. That means people are either understanding or not understood. Okay. Anyway,
Thank you,
thanks
sir. Mani
for the narration. And we have understood that palliative care is an absolute need that is to relieve the pain of the people. And again, the need for an advanced directive, the courage to stop unethical, unwanted treatment, even though the individual is money, has to stop. It's only going to produce resource crunch. May not be a resource crunch for you, but for the nation, it is always a resource crunch. And we all should move to educate ourselves, our own crowd, the need for ethical decision to be followed in the end of care situation, end of life care situation. Well, one has to follow only legally accepted and the correct method of sustaining the treatment, as well as to avoid treatment which are absolutely unnecessary. That means no need to overtreat the patient. And the cost of dying has to be reduced. With this view, I say this particular webinar was a tremendous success in making all of us understand on the particular subject concept. I request Dr. Jayashi Sood to make the formal vote of thanks for the Indian College of Anesthesiologists to all the participants.
Good evening once again, and I'd like to thank Dr. Rajagopal, Dr. Mani, and Dr. Chakra Rao for really having accepted our invitation and speak on this very important topic of palliative care, end of life care, which only justice could be done only by these two speakers. The whole lecture, the whole webinar was so thought-provoking, so moving that people who are really not into palliative medicine could realize that there is so much in it. You cannot just learn it from the books. There's much more to it. And of course, Dr. Chakra Rao, as the moderator, was always, thank you very much for your inputs. And Dr. Radhakrishnan, thanks a lot. And I'd like to thank all of you. And we should be meeting again next week for the next webinar. Thank you very much.
Thank you, Dr. Su, Dr.
Good night.
Radhakrishnan, Dr. Chakra
Thank you,
Rao.
Dr. Mani.
Thank you so
you.
much. Thank you. Bye-bye. Good night.
Thank you, Dabalina, for anchoring us.
Thank you, sir. Thank you so
Yes.
much.
Brahma has improved a lot.
Thank you, Dabalina, and Sainish, if he's there. Thanks a lot. Good night.
Thank you so much also. We are closing
Okay,
here.
Devalina, thank you from me as well. Yeah.
Thank you, sir.
Okay.
Thank you. Okay, we are closing here.